Okay, good morning. Welcome to today's clinical discussion. Happy to be a part of White Army members, where we share our knowledge through the online portals, which many students can access. Today, I'll be discussing about a very important sign, symptom, that is jaundice. Irrespective of the clinical specialty we choose, important to know about this. The learning points, these are all the learning points in our discussion. First, we'll be going through what is jaundice, history taking in a patient with jaundice, examination in detail. The second part of this talk includes interpretation of laboratory tests, imaging which includes simple X-ray, ultrasound, CT scan, MRI. So what to look in these imaging modalities. At the end, I'll be solving some 8 to 10 clinical cases, which will help us in our daily clinical practice. So what is jaundice? Jaundice, all of us know, it's a simple definition. Yellowish discoloration of sclera, skin and mucous membrane due to excess bile pigment in blood and body tissue. The definition is almost same in most of the clinical books. There are other terms which we should know and the difference of these terms with respect to jaundice. Hyperbilirubinemia means, as the word says, it is just increase in bilirubin. If the normal bilirubin is 0.91, let us say the bilirubin goes to 1.3, it is hyperbilirubinemia. The bilirubin has gone up, maybe 20, 30, 1.3, 13, whatever it is. Hyperbilirubinemia indicates increase in the bilirubin level. Icterus is something which is a medical terminology used for jaundice. Cholestasis means there is obstruction for the free flow of bile, whether it is intrahepatic or extrahepatic. Wherever there is obstruction or even the sluggish flow, we call it as cholestasis. Cholestasis may or may not present with plaque. This is very important. Sometimes, I'll be going through my next slides, where patients will have only cholestasis, which is reflected through increase in alkaline phosphatase and GGT in their liver function test, but they do not have jaundice. They may have normal bilirubin. Cholestasis is just sluggish or obstruction to free flow of bile through the biliary tract, both intrahepatic and extrahepatic. Cholestasis doesn't mean always jaundice. Jaundice patients can have cholestasis, but not all cholestasis patients have jaundice. There's a terminology known as latent jaundice, where the presence of bilirubin below a particular threshold is not clinically detectable. Various books gives a different threshold. Roughly, it is 2.53. So anything bilirubin levels above this threshold of 2.5 and 3, so jaundice is clinically evident. Anybody who is observing this sclera can identify, yes, the patient has got jaundice. So these are all the different terminologies which we should be familiar. Sometimes the examiners ask just to confuse the students. So these terminologies should be clear. Another entity known as yellowish discoloration of skin. This is purely a theoretical aspect. Till date, we haven't seen any quinacrine toxicity or carotenemia in our practice, probably the older ones. But just for theoretical sake, you should know that yellowish discoloration of skin is seen in two conditions. One is carotenemia, where people eat excess fruits and vegetables containing this carotene, beta-carotene pigment, and it accumulates in the skin. But carotenemia, when it has to be differentiated from jaundice, the carotenemia pigment specifically occurs in the palmar creases, nasolabial folds, forehead, and other things. Sclera will be always spared in carotenemia. So it is just a theoretical differential diagnosis. Clinically, it's very rare to see these entities. And quinacrine, which is an old antimalarial, which is not at all used nowadays. I don't think we haven't seen any quinacrine toxicity. There will be yellowish discoloration of the skin. The main clinically differentiating features between this yellowish discoloration and the jaundice is that the urine and sclera are two important things. Particularly, even the urine will not be dark and the sclera remains white. So both of these two entities are of theoretical significance. Next, coming to history, it is very important to note down the onset and constitutional symptoms. Sometimes the onset of jaundice may precede the constitutional symptoms. Sometimes constitutional symptoms. Patient notice some constitutional symptoms. He feels he may not be like those symptoms are not significant. So sometimes, those things come first and later the jaundice. If a jaundice occurs from few days to few weeks, a shorter duration of jaundice, few days, let us say, then usually it is due to hepatitis. The commonest hepatitis, infectious hepatitis, which we see hepatitis A, hepatitis E. Sometimes it is drug related. Patient takes some medication for, let us say, another condition, and 3 to 4 days later, patient presents with jaundice. Toxins. Toxin can patients with consumption of these toxins or drug overdose or whatever. So they will present acutely. Within 24, 48, 72 hours, they will present with jaundice. Acute obstruction. Acute obstruction most commonly seen in case of cholelithiasis or CBD stones. Gallstones, when they just fall into the CBD, common bile duct, it causes sudden obstruction, which results in pain and jaundice. So jaundice presenting from few days to within a week or so. So these are all the commonest conditions. Prolonged jaundice, which occurs from weeks to months, is often a part of chronic hepatitis, particularly hepatitis B, C. These patients will have chronic jaundice, bilirubin ranging from 3, 4 going on for weeks to months. Another chronic causes of obstructive jaundice is particularly malignancy. But slowly a tumor grows, and causing obstruction to the biliary tract. So these people also have a long history spanning from weeks to months. Stricture, which is a benign condition which causes obstructive jaundice, also have weeks to months history. CP is nothing but a chronic pancreatitis. We all know that head of the pancreas, where the lower end of CBD joins forming the common bile duct, the common CBD and as well as the pancreas duct have a common channel, and then it exits into the duodenum. So we know that this is where our pancreatic bed is situated. Suppose if there is a pancreatitis, chronic recurrent pancreatitis, there will be stricture formation. There will be inflammation healing, leading to stricture formation in the lower CBD, which causes chronic jaundice. It's a benign condition. There is another entity called fluctuating jaundice. This is very important. Here, there may be a period of anectrus between the icterus, or the levels of jaundice may vary. Sometimes bilirubin will be 16, and after a few days, few weeks, you see bilirubin suddenly comes to 4, 3. 9 patients will have a very high bilirubin. So this is often seen in ampullary carcinoma. I'll be describing this, where there is a tumor at the opening end of the bile duct, presence of stone, and as well as drug-induced liver injury. Sometimes patient may have jaundice few years ago, let us say 6 years ago, 5 years ago, few years ago, patient had jaundice, and now again there's a second episode of jaundice. These two symptoms may not be related or may be related. They may be related in case of, like, say, chronic hepatitis. Patient had initial acute hepatitis B, it just weaned off. Then later, there is a chronic indolent course going on, and suddenly patient presents with cirrhosis or decompensated liver disease, and again develops jaundice. And some genetic causes where there will be history of jaundice in the past, and there will be totally free, disease-free period for running for many years, and again patients presents to us with a jaundice. So how fluctuating jaundice occurs, this is important. In case of fluctuating jaundice, there are a few recurrent causes. As I mentioned, 3 important causes which we should know is that is ampullary tumor. We all know that this ampullary tumor, where the bile duct also goes, and there is a tumor. As the tumor grows, the tumor undergoes necrosis. So whenever there is a necrosis, the tumor gets sloughed off and goes into the duodenum. So whenever there is a tumor necrosis, bile can easily flow from the biliary duct, that is CBD, into the duodenum. So jaundice comes down. And again, when the tumor starts growing, it will be obstructed, leading to peaking of bilirubin levels. That is one of the cause for fluctuating. Another cause for fluctuating jaundice is intermittent stones. There are multiple stones in the gallbladder. Let us say one of the stone just passed from the gallbladder cystic duct into the common bile duct, stayed there for a while, then it just passed off. So when the stone was stuck here, patient will have jaundice, and then the stones pass automatically. Sometimes if a smaller stone passes into the duodenum, then the level of jaundice. Again, so this may be a cause for fluctuating jaundice. Another important cause which we recently saw in a clinical setting also is a drug-induced liver jaundice. Recently, we had a 48-year-old female who had intermittent jaundice. He used to take some form of unauthentic Ayurvedic and herbal medications every 45 days. So whenever she used to take medications, she used to have jaundice for 2 to 3 days. And some of the quack practitioners used to say, no, it is expected for during this 2 to 3 days. She had intermittent jaundice, finally landed in chronic liver disease. So plug in like Ayurvedic medications, not all Ayurvedic medications, the authentic Ayurvedic and herbal medications which have a lot of toxins, so will cause intermittent jaundice whenever patient is on these drugs. And jaundice onset in neonates. This is the simplest slide which I have made, and they don't want to get into details because it's a part of a pediatric evaluation. Simple things to remember: less than if a baby after birth, if there is a jaundice within a day or within 24 hours, there are two eyes. That is incompatibility and infection are the causes. Somewhere between day 3 to day 5 or day 7, we all see physiological jaundice. So beyond day 7, each 3 head should, that is hemolytic disorders, hepatobiliary disorders, and hypothyroidism. Easy to remember. This is my UG day slide. I still remember only this. So the first two entities are unconjugated jaundice. Any jaundice above a week or after a period of 1 week may be unconjugated or conjugated. Associated symptoms are very important. Sometimes, let us say in case of viral hepatitis or so, the prodromal symptoms come first before jaundice. So what happens? So when the prodromal symptoms comes first, they may be very mild. People may experience some myalgia, some headache, feverish, the mild abdominal discomfort or pain. So sometimes these things may not be noted by the patient. So whenever we take jaundice, associated symptoms have to be described along with the jaundice. It's not that we complete the jaundice history and suddenly we write the associated symptoms at the end of the case sheet. No. Associated symptoms means these symptoms are closely associated with jaundice and has to be written in the same list. Very important associated symptom is abdominal. Before getting into causes for the abdominal pain in a jaundice, we have to understand how and what is the mechanism of pain or what causes actually pain. Liver, we know that liver has a particular size. It varies between 9 to 12 centimeters. Of course, liver is surrounded by a capsule. So whenever the liver enlarges, there will be a stretch of this capsule which causes pain. This is a hepatogenous pain. Suppose if there is a slow enlargement of liver or there is a congestion, whatever it is, the capsule is stretched, you get a pain. So that pain is usually a dull right upper quadrant pain. Sometimes patients may not present with the actual pain itself. They say, sir, there is some heaviness in my just below my rib cage. There is some fullness below the rib cage. It is simple hepatogenous pain. Most commonly we see in the clinical setting of fatty liver. Suppose if the liver is inflamed in the form of hepatitis or anything, if it is enlarged, so enlarged liver, inflamed liver, stretching this will cause very sharp pain. That is a feature of acute hepatitis. So suppose liver gets enlarged, secondary to cardiac causes or whatever, CCF or anything, even then the patient will have some dull right upper quadrant pain, dull right upper quadrant discomfort, so which is also a part of congested liver. Another mechanism of pain which we see is a biliary pain. Biliary pain can originate anywhere in the extrahepatic biliary duct. That is the gallbladder, common bile duct, common hepatic duct, and the ducts. What happens? This biliary pain has a specific characteristic. This is very, very important for us to differentiate clinically. In case of biliary pain, so it's sometimes termed as a biliary colic, even though it's not a type of colic. So it is a biliary pain. So what happens? So whenever the gallbladder irritates the stone will irritate the gallbladder and causes inflammation, or the stone stuck in the bile duct causes severe right upper quadrant pain, radiating to back, plus minus vomiting. Few patients may have vomiting, few patients may not have. So severe epigastric or right upper quadrant pain lasting for hours, sometimes radiating to back with a bout of vomiting, most often seen after a heavy meal. We all know that heavy meal or a fatty food will stimulate the gallbladder contractions. So such type of pain, the typical pain which comes after a heavy meal or a heavy fatty meal, which is in the epigastrium, right upper quadrant, goes to back or radiates to back, plus minus vomiting is a typical biliary colic or biliary pain. Another important pain which we see is persistent epigastric or supraumbilical pain, which is dull, which sometimes radiates to back, lasting for many months and years, associated with other features, is pain related to the pancreas. Why are we discussing something pain which is related to pancreas in a jaundice topic? Is we all know that chronic pancreatitis is an entity which can cause stricter or narrowing of the lower end of bile duct, which leads to jaundice. Sometimes malignancies in this part of the pancreas. Malignancies involving the head of pancreas, malignancies involving the uncinate process of pancreas. So, which causes such dull pain, can also cause obstructive jaundice. Another important associated symptoms are fever. Fever is very, very important because it just patient comes to us if there is fever and other things. 2 days of fever is a feature of acute hepatitis. We all know that fever lasting for 3 to 5 days. It may be part of prodromal symptoms in case of viral hepatitis. Fever with chills is another important thing. It is a medical emergency, particularly for our gastroenterology. This thing that cholangitis, whenever there is an extra hepatic biliary, maybe due to stones, maybe due to whatever it is. So if the bile gets infected, so patients will have very high grade fever with chills and rigors. It is a medical emergency. In these cases, the biliary obstruction has to be revealed immediately. Immediately, we have to open up to let out the bile, and biliary obstruction has to be managed. And we should note down that there's an important point. Fever is less likely in a malignant biliary. Malignant biliary obstruction is a slow process where there will be slow compression of these bile ducts or extrahepatic ducts leading to jaundice. So fever is very, very unlikely. Suppose if there is a fever, that the secondary obstruction might be getting infected or something like that. In general, fever is less likely in a malignant. Another important associated symptoms is pruritus. The first thing which we have to know is what is the difference between pruritus and itching is a common symptoms which most of us know, even patients describe. So, if there is an evident skin lesion, let us say somebody has got a patch, somebody has got a rash, somebody has got some skin lesion, and if it is itchy, so it is itching. So it is usually secondary to some dermatological changes. That is itching. Pruritus is a generalized body itching in the absence of evident skin lesion. So pruritus is generalized body itching in the absence of an evident skin lesion. It is often worse at night. This is what we should know the characters of while describing a pruritus. So it is generalized. It is in the absence of an evident skin lesion. Because of repeated itching, patient may develop some skin scratch marks later, but that's not the part of issue. So that when their scratch marks are different, and there is a recurrent itching and other things. So patients may have. But in the absence of evident skin lesion, there is generalized itching. This is often worse at night. That is proven. So it doesn't seem to be a very simple symptom, because sometimes patients are so depressed and so deprived of sleep and other things. So they just say, doctor, you don't have to treat my jaundice, just treat my pruritus. So it is so bad symptom. Short-term pruritus can occur in case of cholestasis, particularly obstructive jaundice. Let us say patient had some stone, obstructive jaundice, and then patient had 1 or 2 days pruritus. We removed stone, obstruction relieved, and the pruritus just. So these are all short-term pruritus. Short-term pruritus are also seen in other important conditions, particularly viral hepatitis. So we all know that viral hepatitis and AE particularly lasts for 2 weeks, okay, sometimes 4 to 6 weeks. And there is a phase known as cholestatic phase of hepatitis, where patients will develop itching. So this cholestasis is intrahepatic cholestasis. You know, the bile canaliculi which are present in the liver. So there will be slightly sluggish flow of bile or obstruction secondary to inflamed liver cells or hepatitis. So even viral hepatitis patients also present with pruritus. And some of the drug-induced cholestasis also causes long-standing pruritus, which is lasting for years and years together with lot of fluctuation, ups and downs, is a part of primary biliary cirrhosis. The smaller duct disease, it is a part of intrahepatic cholestatic. So this slide is not to frighten anybody. You don't have to remember anything. This is just to show that pruritus is not a simple deposition of bile salts under the skin which irritates the skin nerve. So previously, when we were doing our undergraduation, it was taught that it is just the bile salts which gets deposited under the skin, irritates the nerve ending and causes pruritus. There are other intricate mechanisms which causes this pruritus, even at the neuronal level, primary neuronal level, secondary neuron, even at the brain level. Why this is important? Because once previously pruritus was just managed by some antihistaminics and other things. Now we give a lot other medications to manage this pruritus, so that we block this cycle or a pathway of pruritus at different levels. So it can be. So this is only for therapeutic purposes. The summary is that the pruritus is not just the deposition at the skin level, even at the neuronal level and the central level, this pruritus acts. Another important symptom is arthralgia, which is maybe a part of hepatitis B infection, autoimmune hepatitis because of deposition of immunoglobulin, then hemochromatosis. But only thing is, some of the books they mention hemochromatosis and arthralgia, but jaundice is a very rare entity we see in hemochromatosis. Long-standing cholestasis, so we all know that the bile is a very important entity for absorption of fat-soluble vitamins A, D, E, K. So long-standing cholestasis, when there is a vitamin D deficiency, and it may result in non-specific bone pain. So coming to history, it is important to take the history of exposure to drugs and toxins. There are plenty of list, the 20, 30 drugs which are mentioned in various textbooks. But for our clinical practice, we have to note down only a few important ones. Most commonly, it is anti-tubercular drugs. Anti-tubercular drugs are widely used in our country. So ATTs is one of the culprits. And of course, while patient is on ATT for the first few days and weeks, we monitor liver function test very closely. Another important thing, commonly used medication is oral contraceptive. It's very, very important to take this history. Hormonal preparations are also important. Nowadays, many females with the metabolic syndrome and polycystic ovarian syndrome and other entity, polycystic ovarian diseases, they will put on hormonal pills. So hormonal preparations are very important. Psychiatric medication, the new generation of psychiatric medications have very less incidence of cholestasis or causing liver injury. Older ones, in fact, they had. Herbal preparations are very, very important. Nowadays, we see a lot of unauthentic and unauthorized Ayurvedic preparations, herbal preparations coming out in the market for losing weight, for becoming like slim, or for even for gaining weight, for a fair skin or anything. People will be taking these things. And majority of the patients do not give this history unless we deliberately ask them. So otherwise, what happens? They think it is normal supplement because they're marketed like that as 100% side effect free. There are some local herbs and other things. They do not cause anything. We have to take a regular and detailed history of all these things. Occupational exposure, some of the antibiotics, most common antibiotics, what we see here is amoxiclavulinic acid. Sulfa medications we don't use nowadays. Alcohol is another important thing, and it's favored for most of the UG examiners. People keep asking number of drinks, units, and all those things, just to confuse the student and divert him away from the main topic. The people ask these type of questions. Anyway, we all should know that what is 1 unit of alcohol. 1 unit of alcohol is equal to 10 ml or 8 gram of pure alcohol, which is approximately the amount that the average adult possesses in an hour. It means by 1 hour, the alcohol should be metabolized and no alcohol should remain in adult blood. Depends from person to person. This is just an arbitrary setting which they have made, and how our liver functions, the ethnicity and everything, it differs from one person. So this formula, the alcohol by volume by 1000 is equal to number of alcohol units you have to take in detail. Sometimes patient you do regularly they give these values. Doctor, I'm taking 2 pints of beer every day, 1 glass of wine and other things. But some patients may not give exact amount of alcohol we drink. So these are a lot of confusing tables. What I remember is that for women, moderate drink is 1 drink per day, and low risk drink is up to 7. For men, it is 2 and 14. It is easy to remember these 4 numbers, 1 and 7, 2 and 14. I feel that is enough. Again, if you want to still go ahead, you can remember what is binge drinking, extreme binge drinking, heavy drinking, and all those things. As I told before, for that these things are just to deviate the student from the mainstream, and it doesn't fetch anything. At least as a doctors, we should remember 1:7 and 2:14. Even though clinically I don't support anything, sometimes people ask, patients ask, sir, how much can I drink? What is the safe limit of drinking? And all these data from the European data and may not hold good for Indians, because Indians have various reasons to drink, and most of the Indians, I think, they don't involving the social drinking and other things. We don't suggest in clinically. Into continuing with the history of travel and exposure to poor sanitation is very, very important. Suppose particularly in case of infective hepatitis or viral hepatitis. Okay, so it is very important. Northern part of India, we have more of hepatitis E when compared to hepatitis A. In southern, we see A when compared to E. Anyway, nowadays, because of frequent movement and traveling, we see both A and E throughout. The exposure to poor sanitation, roadside eating, and other things are taken, and somebody presents with jaundice. Contacts with the jaundice person is very, very important, because particularly when you're taking history, people are staying in PGs, people are staying in hostels, people had a group trip or something, so where one of them had jaundice, and it's important to note that, particularly the older textbook contain tail inmates and other fancy things. Anyway, it is important when somebody stays in hostel or PG. Occupational exposure to animals, sewage, everything is important, particularly leptospira, which also causes. Particularly here, the presentation will not be in the form of jaundice itself. He has other constitutional, maybe the presenting symptoms, form of fever, high-grade pills, renal dysfunction. And history of surgery is very, very important, particularly when we start our clinical practice. Development of jaundice after what period of surgery makes very, very important part. Suppose in case of immediate post-op period, let us say patient had underwent some surgery, and 48 hours later you get a call, doctor, his left is deranged. Then the causes may be a drug-related jaundice, because the anesthetic medication of antibiotics might have triggered and caused some liver injury leading to jaundice. Or it may be ischemia. It is very, very important. So one characteristic feature of this ischemic hepatitis is sometimes jaundice may not be that evident. It may be just hyperbilirubinemia, because the elevation in bilirubin and elevation in the enzymes are quite different. So enzymes will go up to thousands in ischemic liver injury. Particularly, let us say intra-op patient had hypotension, post-op patient had hypotension. So some cardiac event which led to hypotension. Definitely, there will be form of liver injury, but here there will be hyperbilirubinemia. It may not be a very high value. And post-transfusion hepatitis is also a very rare entity, where a patient undergoes multiple transfusions in case of particularly cardiovascular surgeries, where let us say he undergoes 6 units of PRBCs, 8 unit PRBCs, 10 FFPs, multiple units of cryoprecipitate, platelets, whatever it is. So infective hepatitis is post-transfusion hepatitis. This is a quite rare entity because of tough screening process. Post-op period, surgical injury to bile duct. This is very commonly this thing, people who are not skilled at lab, or sometimes even because of altered anatomy itself. So spectators gets confused around the Kellogg's triangle, and there may be injury to bile. So in the post-op period, this jaundice, and when we go ahead with the imaging purposes, we'll come to know that some injury to the bile. Flip of stones, very, very important. So what happens when the gallbladder, they want to make a cystic duct, they want to remove the gallbladder. Some of the stones which are stuck in the neck of the gallbladder, or even sometimes multiple stones in the cystic duct itself, while milking out, may just get dropped into the common bile duct, leading to jaundice. That's one of the important. Can jaundice develop few years after surgery? Yes, why that happens. Biliary strictures are something which are benign causes, where there will be narrowing of this biliary tract. Can happen after many, many months or something. That is because of ischemia to these things. We should note on that many this biliary system is supplied by multiple blood vessels. So when these blood vessels are injured during surgery, or when there is a tamping, cutting, whatever it is, so people develop stricture over many weeks and months. So even in that case also, there is jaundice because of extrahepatic obstruction. Another important thing that is family history, particularly in children and other things, we look into these things. Genetically transmitted non-hemolytic hyperbilirubinemia. There's a wide list of things which are also the favorite topic for most of the MCQs and other things. So it may be a CN syndrome, Trivial Gilbert, Steuben-Johnson, Rotor, or a BRIC, Wilson's, hemochromatosis, alpha-1 antitrypsin deficiency, hereditary spherocytosis. In all these cases, you see that there is a significant family history where another family member or sibling is affected. It is important to note down, and we should draw a family tree and how the patients are affected. It is very, very important to draw a family tree in those. There are a lot of systemic conditions which are associated, which may be a part of our jaundice evaluation. For example, inflammatory bowel disease. Inflammatory bowel disease in gastroenterology includes ulcerative colitis and as well as Crohn's disease. So what happens? The patients with long-standing ulcerative colitis tend to develop pleurist. Is primary sclerosing cholangitis, PSC, primary sclerosing cholangitis. So if a patient with IBD presents with jaundice, then we have to suspect PSC. Similarly, cystic fibrosis can even affect the pancreas and extrahepatic biliary system. Wilson's disease, metabolic disorders, particularly in children, lupus erythematosus, where the autoimmune hepatitis and other things are common. Sarcoidosis, which can cause intrahepatic cholestasis. And cardiac illness. Cardiac illness is also important. Recurrent failure itself will cause hepatomegaly, pain, and other things. But the jaundice is very minimal in this cardiac. Coming to physical examination. Physical examinations, when you are examining a patient with jaundice, is a very key thing. So there is sometimes what we mistake is a dusky conjunctiva or a dusky sclera, which is commonest entity we see in patients with rural areas, high UV exposure, and other things. However, it is very easy to differentiate this from the jaundice that the covered part of the sclera is not yellow in color. So we should be examined in a daylight or a good LED lights or whatever, but to be examined in a daylight. So jaundice is yellowish discoloration of sclera. Sclera is very, very important. This is the first site. If the examiner asks you what is the one site you want to see, it is better to see the sclera. So any amount of jaundice can be easily picked up in sclera. Sclera is rich in elastin fibers on all these elastin, which have more affinity towards this bile pigments. So it is easily seen there, and particularly with the white bile. In case of mild jaundice, you don't have to remember, you don't have to add that yellow, orange yellow, green yellow. In milder form of jaundice, the sclera will remain very lemon yellow tinge. That's a milder form. And we should remember that hemolysis or hemolytic disorders cause milder form of jaundice. The jaundice may go between 3 to 5, maximum 6, and everything in the clinical setting. So in a hemolytic disorder, the jaundice, the amount of bilirubin rise and everything will not be much. Most of the hemolytic disorders are mild jaundice. So mild jaundice is lemon yellow in color. So let us say the initial phases of viral fever or viral hepatitis. Even there, the mild jaundice is there, is lemon yellow. So lemon yellow is nothing like only hemolytic. No, lemon yellow indicates there's a mild jaundice. So when the jaundice starts accumulating higher, when the bilirubin level goes higher, the lemon yellow gives you something like orangish yellow or dark yellow or something. Okay. So orange or lemon yellow will indicate yellow will indicate a higher degree of this or very high bilirubin. Okay. Let us say we get a patient with some acute liver failure and the jaundice is 30-34. Definitely, sclera will be like this, orangish yellow. But when the high level of bilirubin stays for many weeks, that is in case of long-standing jaundice, the same thing, because of oxidation, it results in greenish color. Okay, so it will be green yellow. So green yellow indicates long-standing high level of bilirubin. Orange yellow indicates high level of bilirubin. Lemon yellow indicates very mild level of bilirubin. Accordingly, we have to assign them to various clinical conditions. Another entity is where else we see yellowish, the jaundice. Okay? In pediatrics, it is very important because pediatrics, we can roughly quantify the amount of bilirubin based on the findings. If the palms show jaundice, or if the palms are yellow in color, the bilirubin level is this much. If the toes are involved, the bilirubin levels is this much. Tongue is involved, the bilirubin levels, approximate values can be estimated. But in adults, it's evident. It's evident. Somebody has a very high jaundice with a high bilirubin. Definitely, you see yellowish discoloration of other parts of skin, palm, toes, and everything. Even another side to look is the lower surface of tongue, even where some amount of mild jaundice also can. So, continuing our physical examination findings. The first picture here indicates a tendon xanthomas, tuberous xanthomas. The second one will indicate a xanthelasmas. Both these conditions are markers of chronic cholestasis. Chronic cholestasis. Cholestasis which remains for many years, particularly seen in primary biliary cirrhosis. So primary biliary cirrhosis, which is a benign condition which lasts for many years. So in case of, these things are markers of chronic cholestasis. So somebody asks you, what are these? Or what does xanthelasma indicate? What does tuberous xanthomas, tendinous xanthomas indicate? They indicate they are nothing but the markers of chronic cholestasis. Okay, particularly intrahepatic. Another entity is presence of cave fishes ring in case of Wilson's disease. Some of the examiners are really fond of asking eye size in jaundice, what else you see in the other. In patients with chronic cholestasis disorders, where there will be deficiency of vitamin A, D, E, K, the vitamin A deficiency changes can be made out. So in disseminated tuberculosis, you can make out some uveitis and other TB-related signs in the eye. So other than just sclera and other evaluations, so KF ring and patient, somebody who's on steroids, you may have cataract, signs of vitamin deficiency and tuberculosis signs can be made in. Another important thing, patients have generalized itching, that is pruritus. So you can see a lot of scratch. This is particularly seen in obstructive jaundice, long-standing malignancies. You see a lot of scratch marks. It is important to describe them as a part of our general physical examination or head-to-toe examination. Another entity is clubbing. Clubbing, we have various causes in other systems, but in general, clubbing is in gastrointestinal system is often seen as a part of IBD, that is inflammatory bowel disease. So patients with IBD also have clubbing, and patients who have this hepatopulmonary syndromes and other things as a part of long-standing cirrhosis or end-stage cirrhosis, end-stage liver disease patients, they have this clubbing. The clubbing, two things you should never forget. One is end-stage liver disease patient has a part of hepatopulmonary shunt or syndrome. Second entity, clubbing will be a part of inflammatory bowel disease. Another few signs which are specific to alcohol-related liver injuries, where the people who have this chronic alcohol abuse, you see dupuytren's contracture, swelling of carotids. And another thing is you see this spider nevi. The spider nevi may be present. It's present both in skin and mucosa. That is one thing we should remember. So because of this deranged estrogen metabolism, the small capillaries will dilate, resulting in the spider web formation with a central arteriole, which when pressed leads to disappearance of this spider. Spider nevi is often seen in the upper torso, and they're also normally seen in some pregnant and people who take this OCPs and other things. Again, the same mechanism because of the high estrogen and other things. And they are often seen in liver disease patients. They can also be seen in mucosa. Sudden disappearance of spider nevi will indicate shock. Anywhere blood loss leading to shock definitely leads to sudden disappearance of this spider nevi. Another important child is the half and half nail or Terry's nail, or even the white nail, leukomycia, which are features of chronic liver disease and hypoalbuminemia. These important things have to be mentioned in the general examination. And paper money skin is nothing but a small lace of vessels, small thread-like vessels occurs in the face, which is a part of chronic alcohol-induced liver damages. and muscular dystrophy also, which indicates just a malnourishment, loss of upper part of fat and other things. Some other important which are specific for alcohol includes loss of axillary hair, gynecomastia, and then loss of axillary hair, gynecomastia, and even testicular atrophy. These are all some of the things which we mentioned in our findings, if present. So when it comes to continuing our physical examination, pulse is very, very important. Tachycardia is often a manifestation of bleed. Okay? A cirrhotic patient in ward, let us say, has a pulse rate of 80 on admissions, and suddenly the pulse rate goes high. That means he's bleeding somewhere, or he has some infection in the form of hepatitis, infection in the form of cholangitis, infection in the form of spontaneous bacterial peritonitis, which is often seen in liver disease ascites. Okay? End-stage liver disease or chronic liver disease patients. Then you have tachycardia. Bradycardia is a part of long-standing chronic cholestasis or long-standing jaundice. Sometimes patients with portal hypertension and bleed, they'll be put on beta blockers. So patients on beta blockers also have low pulse at bradycardia. So bradycardia is a feature of long-standing jaundice and patients with. So BP is very important. So patients who are on beta blockers may have little low BP, or any other medications also have low BP. And patient when suddenly bleeds, so they have low BP. The simple thing. JVP has to be described in detail. This is just to rule out that the chronic congestive symptoms causing liver issues. That's all. So, and then the respiratory rate, large ascites is very important. When the patient has very large ascites, tense ascites, the respiratory pattern also changes. The rate also. Pleural effusions. Pleural effusion is a part of large ascites. Pleural effusion is a part of hepatic hydrothorax and all those things. So hepatopulmonary syndrome, they'll be changing the respiratory. Temperature, if the patient has fever, it is very important to rule out cholangitis and hepatitis. Sensorium has to be described in detail. It's very, very one of the important functions. So hepatic encephalopathy, particularly when we describe, it has to be described in grades, grade 1, 2, 3, 4, Westphal criteria. If there is no clinically evident hepatic encephalopathy, we have to do mental score examination and other tests to just describe the sensorium of it. And person may be delirious. Patients may be delirious in case of alcohol abuse and alcohol withdrawal. So there will be little delirium. Coming to the abdominal wall examination, here we should note down the different scars. Particularly in the jaundice patients, we are worried about a large midline scar. It's a laparotomy scar, or a previous history of cholecystectomy, that is a lap cholecystectomy scar, or an open cholecystectomy. Details of surgery has to be taken. If there are dilated visible veins and dilated veins in the abdomen, we have to note down their flow and everything into palpation. It is important to note down that presence of normal liver doesn't rule out liver disease. So this is very, very important, because sometimes we may not palpate the liver and suddenly examiner asks, is the liver normal? Is the liver normal? So presence of normal liver doesn't rule out. A large liver commonly seen in clinical practice is a fatty liver. Another MPTD entity is a Pett-Chiari syndrome. Hepatitis, which causes inflamed and enlarged liver. So we get a large liver. Very large liver may be a part of neoplasm and infiltrative disorders. In periodic case group, that thing is different. We have a lot of inborn errors of metabolism causing very large liver and other things. But in adults, so neoplasm is one important thing which we have to keep in the differential diagnosis. And infiltrative liver diseases, particularly amyloidosis. So amyloidosis of liver may have a very large. Small liver is seen in cirrhosis. Then rapidly shrinking liver, which is very important. Sudden change in the size of the liver is a medical emergency. It's because we have to get ready for transplant. Acute liver failure, secondary in transplant. AFLP of pregnancy also causes sudden change in the size of the liver. So another important thing is we should understand that even though sometimes hepatomegaly or liver is enlarged, patient may not have jaundice. For example, CCF. CCF liver is enlarged due to backward congestion. Patient may or not have jaundice. So presence of hepatomegaly doesn't indicate that there may be some altered liver function. Leukemia people have a lot of infiltration, very huge liver, not so any jaundice clinically. Myeloproliferative disorders, polycystic disease, and secondaries in liver also. This is very important. So multiple liver mets will not cause very high jaundice or anything. Jaundice is very minimal or least in all these conditions. Another important well palpation is the presence of painful liver. So the star which are blood stars conditions will indicate presence of painful liver. It may be a part of hepatitis where the inflamed liver is stretching, which causes acute heart pain. Budd-Chiari syndrome. There are two types of syndrome. Budd-Chiari is hepatic venous outflow tract obstruction. Okay? The venous outflow tract gets obstructed, the veins get blocked. That is known as Budd-Chiari syndrome. In case of acute Budd-Chiari syndrome, which is often seen in females in the postpartum period or puerperal period or taking OCPs and everything, there will be a sudden obstruction which causes pain. In chronic Budd-Chiari syndrome, pain may not be important. Neoplasm also causes pain, and HSP cardiac failure because of stretch of the liver also pain. These are all some of the common causes for a painful, palpable fever. Spleen may be a part of the clinical findings in case of jaundice. Hemolytic disorders we see spleen, and but in hemolytic disorders, as I told before, level of bilirubin rise may not be very high. There is very minimal rise in the bilirubin. Cirrhosis and portal hypertension. Splenomegaly is a part of portal hypertension in these cases. Hepatic venous obstruction. This is the pathway you should know here, that the portal vein, which is formed by the splenic vein, supramesenteric vein, any block in this pathway will also lead to splenomegaly. Viral hepatitis, there will be non-specific splenomegaly, very mild splenomegaly as a part of reticuloendothelial system response. So splenomegaly is also seen in tumor infiltration and sort of storage disorders. Another fancy sign, very important thing, that is a Kurvacher's sign or Kurvacher's sign, state that in a patient with painless jaundice, because some of the examiners, they expect the exact words. In a patient with painless jaundice, a palpable gallbladder or an enlarged gallbladder, cause is unlikely due to stone, and therefore presumes the cause to be an obstructing pancreatic or biliary neoplasm. It is simple that whenever in a painless jaundice, if the gallbladder is palpable, it is not due to stones. Whenever the gallbladder is palpable due to stones, there will be very painful jaundice. And there is another method why gallbladder doesn't become palpable because of stones, because the expansibility of the gallbladder, the expansible capacity of the gallbladder will be lost when there is a chronic irritation of the GV wall by the stones. It loses its expansibility. So these are all different theories which they see. And there are a few exceptions for it, which you should know. Probably the double duct obstruction and GB neck stone. Auscultation and percussion, we have to, very important to percuss down the midclavicular line and note down the dullness of the liver span. Of course, the liver span, we Indians have a little less, it's around 12 centimeters, somewhere between 9 to 12 centimeters, 2 centimeters less than the Western data. And for auscultation, you have to know where to hear for the hepatic friction rub, splenic friction rub, and other venous hums. This is where you can see around umbilicus with a dilated veins, patient in the standing position, and auscultating his venous hums. So instead of just by highlighting the causes where you see this bruit and rub, it is very important to know the techniques why these things happen. See, venous hum, it is just a excess flow through the dilated. So before appreciating venous hum, we have to palpate for the thrill with light pressure. Because of collaterals in the portal flow, we see venous hum. What does it indicate? Venous hum indicates portal hypertension. The arterial bruit is something which is systolic. We know that increased arterial flow or shunts will cause this. Anything which increases the arterial flow, particularly the inflamed phase, particularly alcoholic hepatitis, and the malignancy which has an arterial flow, excess arterial flow, you get arterial bruit. Friction rub is something which is a localized one. There's an inflammation. The inflammation and the capsule, they're up against each other, where respiration, other things, you get that friction rub, which is in perihepatitis, particular gonococcal perihepatitis and all those things. Gonococcal perihepatitis is very, very rare these days. Very, very important examination which we miss in GI system is examination of scrotum, very, very important, and rectal examination. Examination of abdomen is incomplete without examination of scrotum, that is the mini abdomen, and rectal examination. Scrotum, of course, in the patients with jaundice, we may see patients who are all this chronic alcohol use and everything, there will be a testicular atrophy. Sometimes in an abdominal swelling, we have to observe, even check for the scrotum, because the primary may be in the scrotum and the lymph node mets may be in the abdomen. So even in an abdominal swelling case, scrotum is basically mandatory. We have to also look for hernial orifices when you are presenting. It's not just confined to surgery and other things. So when you have ascites, it's very important to determine the ascites. So most often when you see a tense fluid, it's evident. But when there is a minimal ascites, ascertaining the amount of fluid, the level of dullness, shifting dullness, puddle sign, and other things has to be done. So stool examination, particularly PR examination, is very simple examination which all of us should do, and really it gives a lot of clue to the diagnosis. First stool is a hematochezia. Hematochezia is presence of fresh blood in the stools. Irrespective of whatever patient says, if a patient may say, sir, it is yellow color, black color, gray color, greenish color, greenish blue color, it is as a doctors, we have to do this. It's a simple examination to note down the stool colors. First one is hematochezia. Hematochezia will indicate that the lower GI bleed. Sometimes hematochezia can also occur in upper GI bleed when there's a fast transit time and there's a gush of blood, heavy bleed. You can see presence of fresh blood in the stool. The second one is what you call the echolic stools, where there is an obstructive jaundice. Okay, extra hepatic biliary obstruction. The bile doesn't flow into the intestine, duodenum, so you get a pale stools like this. So pale stool is again an indication of extra hepatic biliary obstruction. The third picture is a black, tarry, sticky. So the description is like this. It is black, tarry, sticky stools with an offensive smell. It should actually. So this is a melena. Melena indicates upper GI bleed, which is proximal to the ligament of breach or something, where after the hematinization it becomes black. So presence of black, sticky, offensive smell stools indicates melena. So it depends on the transit time also, but a minimum around 60 to 70 ml of blood, which has to stay for 2 days, causes melena. This is what the theory says. And the last picture shows silvery stools or a cement-like stools. This can occur in ampullary carcinoma. So basically, people who are well versed with the colors know that black plus white is nothing but silver. Okay, black plus white, we get a gray or a silvery stools. When the black component in the silver stools is blood. Okay, so there is an ampullary carcinoma which undergoes necrosis and it bleeds. So you get a black stool. So since there is an ampullary malignancy and obstruction, you don't get enough bile. So no or less bile plus bleed in the stools will give you that particularly that silvery stools or anything which is seen in as part of periampullary carcinoma or sometimes even carcinoma head of the pancreas. So at the end of summary, see, the learning objectives were very clear. The first thing at the end of summary, after a good history and clinical examination, all of us be able to differentiate whether the patient has got prehepatic jaundice, hepatocellular jaundice, or cholestasis jaundice. This is very, very. So, where is the pathology? Whether it is a prehepatic pathology, hepatocellular jaundice, and cholestasis. Based on the history and examination, at the end of history and examination, we should be able to answer this question. If we're not able to answer this question, again, we have to revise our history and examination skills. We have to retake the history, make sure where is the jaundice, whether it's a prehepatic cause, hepatocellular cause, and the cholestasis. But all if there's a cholestasis, previously people used to use the surgical jaundice. Nowadays, those terms are not used. There is nothing called surgical jaundice. Cholestasis. Cholestasis includes two entities. One is intrahepatic cholestasis, extrahepatic cholestasis. Cholestasis is nothing but sluggish or obstruction for the free flow of bile. If it is happening within the liver, in the smaller bile ducts, within the liver parenchyma, that is intrahepatic cholestasis. If it is occurring out, that is in the common bile duct, CBD, common hepatic duct, whether it's in cystic duct or whether in lower part common tunnel, it is extrahepatic biliary or extrahepatic cholestasis. At the end of the history, we should arrive at this. So, some of the summarizing points were in case of hemolytic jaundice, how to differentiate from hepatocellular and obstructive jaundice. Hemolytic jaundice is often seen in infants with a lot of hemolytic disorders and young adults. Hepatocellular jaundice can be seen in any age, but however, most often seen in young and middle-aged patients. Cholestatic or obstructive jaundice are seen in different age group because it depends the cause. If you go into the benign, which is post-surgical, strict citizen, younger age group, in malignancy, it comes to old age. Presence of prodromal symptoms. Prodromal symptoms includes fever, feverishness, body pain, myalgia, headache, nausea, fatigue. So all these things are often present in hepatocellular jaundice. That's a classical feature of viral hepatitis. In hemolytic jaundice, we don't see unless there is a crisis. Hemolytic crisis, we get this fever, body and joint pains and other. Otherwise, prodromal features indicates hepatocellular. And presence of pain again indicates hepatocellular jaundice. But we should differentiate these two type of pain: the pain of hepatocellular jaundice and pain of obstructive jaundice. In case of hepatocellular jaundice, the pain is hepatogenous. You should know the sharp pain due to liver enlargement and other thing. In case of biliary obstruction causing jaundice, the typical biliary pain which I have described will be there. In case of intrahepatic cholestasis, the pain will not be a feature. So prior surgery is often seen in extrahepatic biliary obstruction, that is EPO, the part of cholestatic jaundice. Stool color is often normal in hemolytic jaundice. Hepatocellular jaundice also is normal. Only in case of obstructive jaundice, we see some clay color stools because of absence of small intestine. Urine color is normal in hemolytic jaundice. It is very, very important to note down. Urine color in hepatocellular jaundice is dark yellow, and again it is dark yellow in case of obstructive jaundice. Anemia may be a feature of hemolytic jaundice, feature of hemolytic jaundice. Hepatocellular jaundice, we may not see any anemia features. In obstructive jaundice, we may see anemia because of malignancy, tumor necrosis, bleed, and other things. So we all know that hemolytic jaundice, the bilirubin is not too high. So we see minimal pale yellow or lemon yellow jaundice. The darker yellow or orange yellow jaundice is a part of hepatocellular jaundice. In case of malignancy, where the obstruction lasts for many weeks, it's a prolonged jaundice, high jaundice, we see greenish yellow. It may be palpable because of, let's say, part of hemolytic jaundice, and hepatocellular jaundice, it's a part of reticular endothelial system response. Unless there is an infiltration or anything, usually we don't see the splenomegaly in obstructive jaundice. Other features, particularly the signs of liver cell failure, which I described in our simple physical examination, important, which is seen in a hepatocellular, because there are signs of hepatocellular failure. In case of cholestatic jaundice, we don't have anything because we may find a lot of patch marks or pruritus and other things. Features of chronic cholestasis is fatigue and tumor, central asthma, tuberous. So these are the features. There are other features which will support hemolytic jaundice, hepatocellular, and obstructive. This is a showing how to differentiate clinically. So by the end of the history, we should be able to differentiate prehepatic, hepatocellular, and cholestasis, intrahepatic, and extrahepatic. The next part of the talk, I'll be discussing in detail how to interpret the laboratory test, imaging, how to interpret the imaging, how to interpret the X-rays, ultrasound, what to look in ultrasound, CT and MRI. Simple things, not complicated things. And I'll be discussing some 8 to 10 clinical cases and how to. So thank you very much. And thank you, White Army team, for providing me an opportunity to share knowledge. Thank you.